Welcome to Session 2B of the Public Health Surveillance course, which is focused on the attributes of surveillance systems. In terms of the lecture content, we'll delve into some of the key attributes of surveillance systems, which can be useful not only for when you're designing new surveillance systems, but also for when you're evaluating existing surveillance systems. For example, it can be useful to assess the extent to which a surveillance system is serving its purpose, or whether a surveillance system is useful from a public health standpoint. This is a list of surveillance system attributes that we'll refer to often throughout the course. We'll go through each of them one by one to give you a sense of what they mean and what they reflect as it relates to surveillance systems. Intensity relates to how aggressively, if at all, the case reports of the event under surveillance are actively pursued by the health department as opposed to just passively received. It relates to whether the surveillance system employs something that we call active or passive case finding. So to understand what's meant by the intensity of a surveillance system, we need to define what we mean by active and passive surveillance. Active surveillance is when health department staff routinely go into the places where new cases might be identified, such as a hospital or a laboratory, and they actively look for new cases of the event under surveillance, such as a diagnosis of TB. Passive surveillance would be when health department staff wait for reports of an event under surveillance to make their way to the health department via established channels. More formally, active surveillance is a systematic and comprehensive solicitation of case data by designated surveillance staff supported for that purpose. So the staff are actively out in the community, in the healthcare system, doing case finding and bringing that information back into the surveillance system. It's a less common form of surveillance, but when finding nearly all cases is a priority, the surveillance system should have an active case finding component to it. However, it should also be pointed out that most surveillance systems that involve case reporting are passive, not active. More formally, passive surveillance means that the collection of case data is based on voluntary compliance of reporting requirements by healthcare providers, physicians, and other healthcare workers and laboratories. There may be a law or regulation that requires they report cases, and those required to report may even be aware of that requirement. And there are usually forms or electronic systems that they can use to report cases to the health department. But at the end of the day, with passive surveillance, health departments are essentially relying on individuals and organizations to follow through with their reporting obligations, which they often don't do. This leads to the surveillance system greatly undercounting the events under surveillance, making it less complete at counting cases. This is what's meant by the intensity of a surveillance system. It can be active or passive or some combination of the two, which we call hybrid. Here's some examples of active and passive surveillance approaches. On the active surveillance side, health department staff routinely could visit emergency departments, reviewing their logs, looking for specific kinds of syndromes or injuries. It could be a surveillance system for severe head injuries. They could routinely review HIV clinic rosters, looking for new cases of HIV that have not been reported to the surveillance system before. And they could routinely query infection control nurses in hospitals about any new cases of encephalitis that they may have known about or treated in the last few days. And the health department could routinely query laboratories or review laboratory records. On the passive surveillance side, we have passive reporting, which is just waiting for providers and labs to report cases under surveillance. Sometimes the health department proactively reminds providers and laboratories of their reporting requirements as a way to increase reporting. This is typically done, for example, when a health department is concerned that there might be an outbreak and they want to help increase the reporting of cases. In a situation like that, the health department might send out an alert to providers and laboratories that alerts them of the potential outbreak that's happening and reminds them both of their reporting obligation and also what kinds of cases to report and how to report those cases. This kind of broadcast alert approach is referred to as enhanced passive surveillance. As you might expect, active surveillance finds more cases than passive surveillance. That's why we do it. But there have been some comparisons of the completeness of reporting for the same condition and time period under active versus passive surveillance intensities. In these examples of surveillance for hepatitis and measles, rubella, and salmonellosis, when there's active surveillance, there were substantially more cases ascertained than in passive surveillance alone, by a factor of 1.5 to 5 times more cases. So if you have an active surveillance system, you're more likely to have more complete case ascertainment. But as you also might expect, because active surveillance is more intensive, it's also more expensive. This slide shows a comparison of the costs of two different approaches for hepatitis surveillance, and most of the difference in the expenses relate to the personnel costs, so the people who are actually going out into the field and looking for those cases. So when you're deciding whether there needs to be an active component to a surveillance system, studies like this can help quantify the costs in relation to the yield of cases. In other words, you can compare the total costs and the cost per case and make a decision if the extra expense might be worth it given the goals of your surveillance system. The simplicity of a surveillance system is an attribute that refers to how easy it is for the surveillance system to operate as a whole, as well as its different components. For example, how easy is it for a provider or a laboratory to report a case? Is it simple? Is it really complex? Is it paper-based? You want your surveillance system to be as simple or as streamlined as possible while still meeting its objective. And if you can achieve that, if you can streamline it, you can get much more timely data and use much fewer resources than a more complex system. The flexibility of the surveillance system is an attribute that refers to the system's ability to accommodate changes or updates, including changes to things like the operating conditions. Perhaps the surveillance system with one set of information system needs, or perhaps the surveillance system started with one set of information needs, but then it became important to add information elements. An example that I'm thinking of for this one is during the SARS-CoV-2 pandemic, early in 2020, the case reports contained really sparse amounts of information. They really only had like the date of diagnosis, age, sex, and geographic information. But it was clear pretty early on that there were some major racial and ethnic disparities in the rates of SARS-CoV-2 cases and hospitalizations and deaths. The surveillance system didn't have good information on race, ethnicity, and as a result, there was a lot of pressure and demand for that information to become available so that disparities could be better tracked and characterized and understood and intervened upon. So the surveillance system needed to change to be able to capture this information on race, ethnicity. And that's an example of an increase in information need where you might need to change your surveillance system to get additional information. Sometimes the case definition might change, and that's, then it's a question of how easy is it for your surveillance system to accommodate those changes in the case definition. Is it just a question of changing some code and an electronic health record, or do you actually have to train providers about the new case definition, what it means, and how to report? What if the forms have to change or the reporting procedures have to change? Are those easy changes to make, or will it be very labor intensive to do so? And what ability is there to track new health events within the system that might be needed? Each one of these things relates to the flexibility of the surveillance system and whether or not it's easy to adapt to change when needed. The acceptability of a surveillance system is an attribute that refers to the willingness of individuals and organizations to participate in the surveillance system's processes. So the surveillance system may be live and there may be reporting regulations and requirements as part of state or city law, but you still might have different levels of engagement in reporting to the system. This could relate to the acceptability of the surveillance system among those that you need to be involved and engaged in participating. So how do you gauge the acceptability of a surveillance system? You can look at providers or labs that may be seeing cases in the community that are reportable, and then assess the proportion of those providers or labs that actually report to the system in a given month or a year. If that proportion is low, it suggests the acceptability of the system may be low. It could also reflect a low level of awareness of reporting requirements, which is another problem that health departments need to deal with. And then even among those who do submit reports, you can get a sense of how acceptable the reporting process is to them by taking a look at some of the submitted forms and checking across all the different fields to see how complete they are. If they're only filling out like three to 10 fields on the form, that speaks to how acceptable the reporting process is for them. It's less acceptable than you would like. You also may need to interview individuals who are cases as part of the system. And if you're finding the interview acceptance and completion rates are low, that speaks to the acceptability of the surveillance system as well. And in many cases, the acceptability of the surveillance system is really influenced by how much time is needed to complete a report to the health department. And those things in turn get back to simplicity. You want to keep the surveillance system as simple as possible while also enabling it to achieve its core goals and objectives. This can help lead to a more acceptable surveillance system. You've already covered sensitivity and specificity and negative predictive value and positive predictive value as part of your early coursework, usually when discussing screening programs or diagnostic tests. But we can also apply these same concepts to surveillance systems. Formally, the sensitivity of the surveillance system refers to the proportion of cases of a disease or a health condition detected by the surveillance system. What proportion of cases that occur in the community are actually detected by the system? You can calculate it according to its usual formulas here. But we can think about the sensitivity of a surveillance system in at least two ways. Its sensitivity to detect individual cases, as well as its sensitivity to detect outbreaks of multiple cases that occur in the population under surveillance. So how sensitive is the system at detecting one case that occurs, or any one case that occurs, and how sensitive is the system at early detection for outbreaks? These are two different concepts, and how important each is relates, of course, to the goals and objectives of your surveillance system. In thinking about sensitivity for individual cases, a surveillance system that's highly sensitive will miss few cases that are occurring in the community. If you need to have a highly sensitive system, one way to do it is to have a broad case definition. Another is to encourage providers to report possible cases on suspicion as opposed to waiting until they have diagnostic test results and confirmatory diagnoses. You can also have active surveillance and a number of other strategies that can help ensure you miss fewer cases that are happening in the community. However, having a higher sensitivity results in a lower positive predictive value. That is, you'll have more individuals reported to your surveillance system that don't turn out to be true cases. If you have a high sensitivity for outbreaks, it means that for most of the outbreaks that occur in the population, there'll be some kind of signal in your surveillance system suggesting there's an outbreak going on. In this situation, you can also use a threshold in the number of cases that are reported to the surveillance system in a particular time period or geographic location to trigger an alarm that indicates a potential outbreak. To increase sensitivity, you'd use a lower number of cases as the threshold to trigger an investigation of those cases as a possible outbreak. And to decrease the sensitivity, you'd increase the number of cases to trigger an alarm. Again, this gets back to the goals of the surveillance system. If detection of outbreaks is a major goal, as it is for many surveillance systems, then you need to be thinking about both sensitivity for individual cases as well as sensitivity for outbreaks. Positive predictive value of a surveillance system refers to the proportion of people identified as cases who actually have the condition under surveillance. So if you have 100 cases reported each month, what proportion of those reported cases actually turn out to be true cases of the condition under surveillance? That's the positive predictive value of the surveillance system, calculated using the formula here. And it relates to its efficiency. So if most of the cases reported actually turn out to be true cases, then there's less sifting through information to try to make case status determinations on the part of the surveillance system and its staff. If you have a high positive predictive value in your surveillance system for cases, it means that most of the reported cases are in fact true cases. And you can increase the positive predictive value of your surveillance system by using a narrower or more specific case definition. In contrast to how you tweak the sensitivity of a surveillance system, you essentially do the opposite to increase specificity. You can encourage clinicians and labs to report only those cases that are confirmed, not just the ones that they suspect might be cases. There are a few different strategies you can use to influence the specificity of a surveillance system, and when you increase it, it often comes at the cost of decreased sensitivity and timeliness. Like with sensitivity and specificity, you can also think about the attribute of positive predictive value as applying to outbreaks as opposed to individual cases. So the surveillance system may or may not have good positive predictive value for individual cases, but it could still have good positive predictive value for outbreaks. So if a surveillance system has a high positive predictive value for outbreaks, it means that when your system says there might be an outbreak going on, it's usually not a false alarm. You don't want to have to investigate too many clusters that turn out to not to be outbreaks because it's resource intensive. At the same time, missed outbreaks can be expensive too. And then there's the negative predictive value for outbreaks. When the negative predictive value for outbreaks is high, that means that when a system is not signaling that there may be an outbreak, you can reliably expect that there's not an outbreak happening. A way to increase the negative predictive value is by increasing the sensitivity. And the way you can know that it actually works is just to gain some experience over time by trial and error with the surveillance system. You can also go back historically and look at all the known outbreaks, array them on a timeline, and then look to see what was detected by the surveillance system during and in between those outbreaks. How much, if at all, was it signaling in situations when there was clearly no outbreak happening? These dimensions of sensitivity and specificity are complementary to each other and some of the surveillance system attributes that we've covered as well. Hopefully you're beginning to appreciate how they can be interrelated. The completeness of a surveillance system is an attribute that refers to the completeness of case ascertainment. So what proportion of reportable cases occurring in the community are actually captured by the surveillance system? Visually, you can think of the large circle as all the cases that are happening in the community. And then within that, you can imagine that some proportion of the cases came to the attention of providers. Some came to the attention of labs. Some came to the attention of both providers and labs. And all of these would be the reportable events. But what proportion of reportable events are actually captured by the surveillance system? It's a subset of all the reportable events, and the number of cases that are captured as a proportion of all cases that came to the attentions of providers and laboratories is referred to as the completeness of case ascertainment, or the completeness of reporting in the surveillance system. Most surveillance systems are nowhere near 100% complete, and I would add that many surveillance systems don't necessarily need to be 100% complete or even close to that in order to achieve their goals. So when we talk about completeness, remember that it's an important attribute of our surveillance system, but it isn't always the most important. It really depends on what the goals are. The other point I want to make on this slide is that there's some overlap between providers and labs in terms of what they report. You can see that in this schematic, there are cases that providers report that laboratories did not report, and vice versa. And there are cases that will be reported by both providers and labs. And this relates to the redundancy that I alluded to earlier. Requiring both providers and labs to report can help improve the completeness of the surveillance system. And you can see why here, because they're each reporting sometimes overlapping, but sometimes complementary groups of cases. That's how it improves completeness. The other thing that's really important about this, and we'll come back to it with examples, is that the kinds of information that labs report and providers report are different and also complementary. So you can get a sense of clinical information and sociodemographic information from providers, and you get the laboratory test result from the labs. Together, that creates a more comprehensive set of reports and documentation in the surveillance system. So here's a concrete example of the concept of completeness. This is the infectious disease shigellosis. The large bar represents all the people who are infected with shigellosis in a given year, and the next bar is the proportion of those cases that are symptomatic. And it turns out that in this case, 24% of people with shigellosis actually never have symptoms, so they may not ever know they had it, and they might not ever come to the attention of a surveillance system. The third bar represents the proportion of those with the infection that seek healthcare for their symptoms. Only then can a healthcare provider possibly report a case. Importantly, healthcare providers may or may not order a lab test to confirm the diagnosis for each patient they see. Sometimes they don't need to, depending on the situation. Only when they do order a laboratory test can a lab report that information to the surveillance system, and only then when it's positive. So here you can see that only a fraction of those that consult a physician also have a laboratory test conducted. And then further, only 7% had a positive culture test from the lab, which is what laboratories would report to the health department. So this highlights that some true cases can have negative laboratory tests, and it's another reason for redundancy. And you can see the kind of drop-off and how the information reported by healthcare providers and laboratories really represents a small subset of all the cases that are occurring in the community, at least for this particular health condition. The other thing that's important here is the concept of timeliness. The graph also shows the number of days that have elapsed since occurrence of each of the events on the graph on the x-axis. And by the time a culture might be obtained and a positive result might be reported by the lab, 10 to 11 days have elapsed. So this speaks to the minimum time frame in which the health department could become aware of a case of Shigella detected by a positive culture result, for example. It takes time for labs and providers to report to health departments. It takes time for them to gather and process the information. Another important surveillance system attribute is its representativeness. To what extent does the surveillance system accurately portray the incidence or prevalence of a health event by person, place, and time in the general population or in the population that's under surveillance? Related, how generalizable are the estimates and observations from your surveillance system? When you assess representativeness, you want to seek to identify important subpopulations that may be systematically excluded from surveillance or may be overrepresented in the surveillance system. Going back to the last example, you can see with shigellosis that if people are not accessing the healthcare system even when they have symptoms, maybe because the symptoms are milder or because they don't have insurance or they otherwise are less inclined to go to the doctor, they might be different from those who end up seeking care and end up captured in the surveillance system. So I'm sure you can appreciate how some populations might be systematically under or overrepresented in surveillance, making it not representative. On the flip side, surveillance systems don't necessarily have to be representative in order to achieve their goals. If the goal is to detect outbreaks, you don't need to detect every single case. You just need to detect enough cases to indicate that there's an outbreak happening. Another example is that a surveillance system that only captures more severe cases or those accessing healthcare may still provide reliable information on the direction of trends. So a surveillance system doesn't always have to be representative in order to be effective, but it sometimes really is important for representativeness. It depends on the surveillance system goals, as always. We alluded to the surveillance system attribute of timeliness a few slides back with the shigellosis example. It relates to the time that elapses between the occurrence of the event under surveillance and when that information is received by the surveillance system and it can be acted on or disseminated by the surveillance system. Timeliness is really important for some surveillance systems and less important for others. Where there's an outbreak that needs to be investigated and contained quickly, timeliness is really important. If it's a chronic condition like a cancer, for example, timeliness is less critical. But if timeliness is critical, you need to focus on those other attributes of your surveillance system to help you improve timeliness. For example, active surveillance is very important to increase timeliness. Relying on electronic health records or other electronic forms for reporting can help increase the timeliness. You can encourage providers to make a phone call in addition to sending an email or submitting an electronic report when they suspect a case. And of course, stepping up provider and laboratory education, rapid review of cases by surveillance staff as they come through to the health department, and making it easier for people to report things quickly are other ways that the health department can make timeliness improve. So those are some of the key surveillance system attributes. I returned to the list here because, again, it's a list of attributes that we use when we're assessing or evaluating the surveillance system in relation to its goals. We'll be referring to it a lot, to the terms on this list a lot over the course. And we'll be talking about evaluating surveillance systems later, but it's important to have these conceptual terms in mind when trying to assess surveillance systems, including when trying to assess the extent to which it's effective and useful at achieving its goals. And I'll just end here with a quote from one of the giants in the field of public health surveillance, Alex Langmuir, who said, "Good surveillance does not necessarily ensure the making of the right decisions, but it reduces the chance of making the wrong ones." I like the quote because it really drives home the point that surveillance, public health surveillance, is imperfect. Surveillance systems are often flawed in many ways, but they can be designed and they can evolve and be managed in such a way that they can still be very effective at their main goals, even though they can appear to be imperfect in many ways. So that's it for this session. Just a quick preview here of what's to come. We've covered a lot of principles so far, and now we're poised to move on to some specific examples of a surveillance system. So next week, we'll be covering the detailed example of HIV/AIDS surveillance in New York City, which is a notifiable disease surveillance system that includes provider reporting, laboratory reporting, and active case finding. After that, we'll move on to vital registration, which is registration of births and deaths and how these are used for surveillance. This is moving into different sources of data for public health surveillance. So vital registration is one. Then we'll have a lecture followed by how surveys can be used to do surveillance for behaviors and risk factors. And in early October, we'll look at the use of administrative data sources for public health surveillance. And this includes things like hospital discharge data and healthcare claims data. So have a great week.